So, Dr. Rebecca Shadowen, thank you. You are on the front lines as an epidemiologist and infectious disease specialist with the Medical Center in Bowling Green. I want to revisit, okay, you and I talked probably over a month ago when things were really
Mhm.
just starting to heat up. And what I'd love to look at right now is now you've had over a month to be on the front lines and the COVID-19 made it to the United States. What have you learned in that time?
Gosh, there's so many things. Barb, we've learned a lot about the disease, and we've learned, I think, um, where we need to be going. But the biggest part is what we've learned about each other. We've learned a lot about our community. We've learned about people who have creative ideas and are really team players. We've learned how much we can do and how resilient we are. We've learned a lot.
Wow, that's a big, I never thought about it in that regard. You said you learned also where we're going. Where are we
Mhm.
going?
Blindly into the future. We're going forward to um, see how much curve mitigation we can do as we begin to reopen some of our society, and how well we can manage things until we're able to have real treatment and vaccines out. And I shudder to say that's 2021, but it is. And so we know that as long as our communities are able to continue to meet what we're asking of them, that our society will begin to look a little more familiar and be more functional. If we can't meet that as a community and as a society, then we're going to see a lot more cases and have to shut down again.
We learned today that the hospital census at the medical center confirmed 20 positive COVID-19 cases hospitalized here in Bowling Green. You, as an epidemiologist and infectious disease specialist, can you share with us the first time, your first COVID-19 patient, what that was like for you?
Um, well, there's a certain degree of relief that, well, we finally have this. So all of the preparation you do, it becomes reality for people to be able to understand it and actually perform what they were trained to do. There's a lot of sadness in that because we know that once it's here, and it's here before we're ready. We really needed to be able to test. We really needed to be able to treat, and we really needed a vaccine, but that's coming. So the hard part has been knowing that we had to find a way to manage once it's here. So very solemn, but also relieved because our people were ready to manage. And that was such a good feeling from that perspective.
And as we referenced, you've been doing epidemiology for a while.
Yes.
How is what we're doing right now with COVID-19 and what you are having to do as you approach the day-to-day front line, how is that just so different than what you've known?
Mm-hmm. So it's certainly different than everyday patient care, but it's not appreciably different than the other things that we've done in the background that most people didn't know about. And I think that's been sort of an eye-opening thing to me because I have been taking care of outbreaks of infections in healthcare behind the scenes. And most of the time people didn't want to know about it. They just wanted us to take care of it. Now they're all understanding even terminology I didn't think they could understand. So the conversations are at a totally different level, and having people so much more engaged is really different for me. It got me a little out of my comfort zone at first, and now it's become more familiar. So it becomes a bigger world for me when we're talking about epidemiology now than it
And
was
what
before.
about with COVID-19? There seems to be so much fear. Now, you've treated patients with infectious diseases over the years, and I'm sure they're fearful once they have a diagnosis. But this one we know so little about that fear factor really must play into the patients you treat.
Not just the patients, but all of us. Now more than ever, I think that knowledge is empowerment. And if we keep giving ourselves the information that we need to be able to function reasonably and to protect ourselves, then you feel like you have some degree of safety. But in this world, all the way around us, there really isn't a complete safe zone, never has been. So this is not particularly different than any other time if you understand what we're asking of each other. But it is something that is a growing base of knowledge we have to adapt to as it goes along.
You referenced the 2021, just in all reality, there's no crystal ball, but it is going to likely be at least 2021 before we see a vaccine. In the meantime,
Yes.
what do we do?
We do the best we can, one day at a time. That's what we've always been doing, and it's no different than what we did yesterday for today. So we as a population, but particularly in Kentucky, where we're vying for one of the top spots of the best controlled outbreak, need to stay that course. We're getting really good advice for one of the few times in our lives we're seeing health systems cooperate and governments cooperate and giving us real information that helps us understand where we need to be. We need to keep listening to that. Just because we're loosening up our society to try to become functional again doesn't mean that we stop all of the precautions that we've been doing. Those are what has saved lives. And until we have treatment vaccine, it's the only thing that's going to save lives. So I'm relying on our communities. They've been tremendous people, and I'm relying on them to continue to be so, as hard as it is for us, but to continue to be so.
So the testing sites, as we speak, they are opening up more testing sites all over the state of Kentucky. Bowling Green will soon have a testing site. A couple of questions. How is it determined where the testing site will be, the drive-through testing? And what do you hope that's going to gain for us?
Well, so I think it's going to be at South Warren's parking lot on Tuesday to Thursday next week. We've been able to test all along, though we have limited it inside the hospital for those people who are most ill. And anytime you have an outbreak, when you have limited testing, you start with those that you need to apply it to most ill. Luckily, we've been able to expand that as more testing has become available. And so today, any physician can order a test and take it on you and send it out to a laboratory, even in their office if they want to. These testing sites, though, will give us interesting information that we don't really have, and that is how many of us in Kentucky, at least on a reasonable estimate, have had or have this infection. If we knew that on a population basis, we could get a little better predictors of what we look like on our curve, number of cases, and our capacity needs in healthcare over time. It also gives us a little better idea of how cautious we need to be. So if very few of us have had the infection or are infected, then we have a large population still susceptible, and we need to be a little tighter on control.
How effective is the testing, in your opinion?
Yeah, we initially didn't really know, but we do have some information out, and I'll tell you this, that in the first 3 to 5 days when you acquire the infection, your tests are not quite as good of picking up the virus. But when you get to around 5 days or so, they're really good. If you're symptomatic, they're excellent. So they're a little better than we thought initially, but that first window of 3 to 5 days may be a false negative. And the big issue with this negative thing is that it's not a get out of jail free card. If you're negative, it doesn't mean go out and have a good time. It means please stay in social isolation, and please stay safe at home because you're still susceptible, and a negative doesn't always mean a negative. The contrary to that is very important. So if you are immune to the virus, it doesn't mean you won't carry it. You just won't get sick with it. So even if you have immunity or have had the virus before, you need to be sure that you don't spread it. So you still have to have, social distancing and do your hygiene appropriately.
Wow. So yeah, so basically you might have had it or you test negative, but you might still be carrying the virus. So you go to work and you could spread it to someone else who's vulnerable.
That's right.
Let's talk about community spread. How is, like I said, you and I talked a little over a month ago when we were just learning some things about COVID-19. What do we know now as far as spread, community spread for sure?
I can't tell you we know everything, Barb, still. And until it's all going to be after the fact. So people ask me questions, sometimes say, ask me that in 6 months, and I'll be able to answer the question because the retrospective information is a little bit better for us. But I can say this, that infectivity on surfaces is far greater than we realized. And so the environment becomes a big deal. Those people who are touching their face, touching the surfaces of things, whether it's the cart at Kroger or the table at a restaurant or any place, that have the virus in their hand are more infective when somebody else touches that, since it survives there for 3 days. And then we touch our face. That route is a major transmission route. If we distance ourselves, and by the way, the rule of thumb has been 6 feet. What we've learned is people keep maybe 3 feet if we say 6 feet. So now we're saying 6 to 10 to try to push people back a little further, because we tend to crouch in on each other. So that distancing is a little further, but distancing is still extremely effective for airborne, aerosolized transmission route.
PPE, we hear so much about the lack of masks, the lack of swabs to do the testing, personal protective equipment, and frontline workers who are putting their lives on the line to do this. Where are we at as far as PPE is concerned when we speak about the medical center and its facilities?
So we started really early with concerns about PPE and how we sustain that. And so we've actually turned over every single avenue we can to try to be sure we have PPE. And we've signed up with a company in Ohio that sterilizes our N95 masks and are sending those regularly out to be sterilized. We have a 7-day reuse policy on some of our equipment. We've had some community people who have stepped up and made gowns out of Tyvek that we use on buildings for us. And so we're doing pretty well. We have a couple of people at the medical center that are just wizards with this and have just worked day and night to keep us in PPE. So currently we're doing pretty well. Now the question we all have in medicine is how sustainable is that over time? Because that is a rate limiting factor of what we can accomplish. And so when we open up, one of the factors of being able to reopen in healthcare is, can you sustain your PPE in order to take care of patients?
Are we opening up too soon, in your opinion?
I think any time is probably too soon. But if we wait until January of next year, we won't exist as a society anymore. So we have to decide how we're going to do that as safely as possible. And so medically, there's one side of it, and then practically, there's another side of it. And although medicine is really good, sometimes it's extreme when we have a society that needs to function. So I do believe it's time. I actually kind of personally feel like we may have shut down too soon for Kentucky, because we didn't have a lot of cases for a while. And that made it more difficult for all of our businesses. At this time, if we're opening too soon, it's going to be because our behaviors don't continue to comply in our communities.
We've heard a lot about how this virus affects a certain vulnerable community, and yet it doesn't discriminate. So in your experience at the medical center in Bowling Green, with more than a dozen positive COVID-19 cases and at least one death, I understand, what are you seeing as far as who is most vulnerable?
You know, Barb, this is the hard thing from a personal perspective to say, but if you acquire the virus and you're one of those that has severe disease, it really doesn't much matter because it's 100% for you. The vulnerable populations are infants, newborn infants under 6 months old, and then elderly people, certainly. But when you add heart disease, lung disease, obesity, inactivity, diabetes to the mix, it just greatly increases your chance of not doing well. Having said that, there's some people quite old with comorbidities that have done well. So the issue is your health in general. And I think the bigger issue with comorbidities, if you have diseases that are not controlled, not addressed, your chances are much greater that you're going to have a problem with it. So it begs the issue of getting people to come in now. You know, the hospital's still safe. We're still doing very careful control of everything, but people are waiting too late to come in, so their diseases are not controlled. And you take a population, spread some coronavirus in there, and that's going to be a real problem.
So you're referencing people who maybe are having heart attack symptoms or stroke symptoms, and they're holding off going into the emergency room because they're fearful they'll contract COVID-19?
It's that, or it's even their physicians' offices. because they're fearful that we're not going to do that. And they actually closed us down and we could do telehealth and limited visits. So there's been a real problem with trying to get people in for their regular visits to control their COPD or to control their diabetes or to take their hyperlipidemia medications and cholesterol medication to get their high blood pressure down. So what we've done is push that off and refilled medications. And then a lot of patients just haven't bothered to pay much attention to that because of the epidemic, the pandemic.
And we understand that nationwide, COVID-19 is disproportionately affecting minorities. From what you've seen in Bowling Green and the medical center, are you seeing any of those numbers reflected?
We're seeing across the board. We really are seeing across the board people. I think, we all worry terribly in medicine about access to care for those vulnerable populations and for those people who have lower socioeconomic classes or those people who are impaired because of their immigrant status. We're in a sweet spot in Bowling Green, honestly. Access to care is pretty good, I think. And certainly my practice have never turned anybody away for any of those reasons. And I think what we're seeing is wide access to whoever needs it. And that's going pretty well, but we do see all aspects of our classes affected.
If you would now, there are so many misconceptions about COVID-19, but there's also so much we don't know. If you could, you've got an audience right now, what are some of the misconceptions? Because people are fearful that maybe it lives in their hair. If they brush their hair, it will get on the counter, their shoes. Do you have any information to enlighten us in that regard?
Yes. The distancing is the most important thing. In studies looking at healthcare workers who are taking care of patients who have definite COVID-19, we've tried to recover the organism from their shoes and from their gowns and from their gloves and from their masks and from their face shields, from their hair and from their head bonnets, and we have not found it there. What we have found in small studies is all over the surface of the rooms.
Oh.
And we have found it in the air in a very small radius around the patient. It falls quickly out of the air. So if you're 6 to 10 feet from a person, your risks are minimal. And if you surface clean and you wash your hands well, your risks are minimal. Wearing a mask does not protect you from acquiring the infection unless it's a fit tested, very tight N95. Wearing a mask keeps you from spreading from your face outward to other people. So the general mask use was not a backstep from any healthcare authority. It was an additional plan when we had generalized spread among our communities. These are known things we do in epidemics. There's a staged approach to these, and people view this as, oh my goodness, look, they're changing their mind. No, it's at that point it's time to institute a new control. So the general mask wear is important now, where it wasn't important a month ago when we were talking about it because of the lack of it. So wear your mask, distance yourself, use your hand hygiene, and disinfect surfaces. That is the safest thing you can continue to do.
Have you been tested for COVID-19?
I haven't, but I don't have any symptoms, so I think I'm okay.
And should, now that we are seeing more opportunities for testing in the Commonwealth, would you encourage everyone to get tested? Only those with symptoms? How would you square that?
Yeah, I do think all healthcare workers should be screened, and there are two reasons for that. One, and also emergency response people and first line people and police. One is that if they are positive, they're going to recover from the infection, and when they recover, then they become a little easier to manage as workforce, and that's kind of important. And the second reason is that they can donate plasma, which is something we give to people who are very sick with the disease. So I think the biggest reason to be tested is if you have symptoms or you have been exposed to someone. If you are regularly exposed in your workplace and you'd like to be tested because you're a family, that's fine too. Those are the reasons to be tested. Once we find people who have recovered after 14 days of no symptoms, they can donate for patients who are sick. And that is one of the things that is making a difference in the care of the patients. Please remember that well over 95% of people who acquire COVID-19 are going to live through and be fine. We tend to get in this mindset that, oh my goodness, I'm going to die if I get it. And the vast majority of people do not. It's only a few percentage that do poorly, someplace around 6% or so that get severe disease. And of those, over half are going to survive, it looks like.
Do you think we'll see a resurgence? Okay, so maybe we make the curve, we get, we see things slow down, and then come fall. Do you think we'll see a spike again?
It's going to depend on how much movement we have outside the homes. That's going to be the biggest concern, because if we reinstitute school, kids are more likely to be asymptomatic, and of the super spreaders, we call it, those people who shed a lot of virus, it's more likely to be the young people. So they may not be sick, but they may give it to everybody else. So that's going to be our big red herring.
Leave us with some words of wisdom.
You know what? Every day is really important. So I think living each day and living into each day how we want our lives to be is extremely important. What we put in our head is who we become. So pick and choose the things while you have the time now that you want in your life carefully.
Dr. Rebecca Shadowen, epidemiologist, infectious disease specialist from the Medical Center in Bowling Green. You're watching Coffee Near Me. I'm Barbara D. coming to you from my dining room. Welcome to my home. Keep the conversation going. What would you like to have a conversation about? And Dr. Shadowen, this is a bit lighthearted, and a little levity is always kind of good. But we always ask our guests, if you could sit down and have coffee with anyone, living or dead, who would that be?
Albert Einstein.
Yeah, that's a good one.
Yeah. Albert Einstein. I understand he had a great sense of humor in addition to being just a genius. So I'd love to sit down and see what he's like. I'd really like to have an audience with he and Edgar Allan Poe, I think. Wouldn't that be an interesting combination of people?
That would be an unusual dinner party. Please invite me.
I will.
Thank you so much, so much.